video on arterial line. I hope you will find it useful. So first, a few formulae that is very important. Cardiac output is equal to stroke volume into heart rate. Blood pressure is equal to cardiac output into systemic vascular resistance. Systemic vascular resistance is also known as afterload, as peripheral vascular resistance, as vasomotor tone. MAP, that is the mean arterial pressure, is equal to 1/3 systolic blood pressure and 2/3 diastolic blood pressure. Pulse pressure is equal to SBP, that is systolic blood pressure minus diastolic blood pressure. Now, when we talk about blood pressure is equal to cardiac output into SVR, it is actually mean arterial pressure MAP, which is equal to cardiac output into SVR. Now, before we go into the intricacies of arterial line, it's very important to make sure that the arterial line is showing your correct BP. In one study, it was seen that 30% of the arterial lines were showing incorrect blood pressure. So how do you make sure that your arterial line is showing the correct BP? And this becomes very important when the blood pressure falls low. Supposing the blood pressure suddenly becomes 80/50. So you have to be sure that the arterial line is showing the correct BP, right? So first you check the non-invasive BP at the same time. If it's the same, then well and good. However, if the non-invasive BP is different, then you need to be sure that the blood pressure which your arterial line is showing is correct or not. And when you apply the NIBP cuff, please make sure that the cuff is of appropriate size. If the arm is thin or obese, your NIBP will show faulty readings. In a thin arm, if you apply the normal cuff, the blood pressure will be erroneously low. And if it's an obese arm with a normal cuff you apply, the blood pressure will be erroneously high. So please apply the right cuff and check in both the arms. Sometimes there can be a discrepancy in both the arms. There should not be a more than 10 mmHg difference in both the arms as far as blood pressure is concerned. Up to 10 mmHg is normal variation. So then you check the transducer position and then you do the zeroing and you check whether there's any air bubble or any clot or any kinking in the line. You flush the line, and if after this you get the blood pressure well and good, otherwise you have to check for damping. So I will explain the flush test for damping in the end. So you've done all this, still you're not sure, then you have to change the transducer and you have to change the line finally to get the correct BP. If damping shows that the the flush test shows that the line is damped, then you have to take appropriate measures and you have to change the line if it's not getting corrected by flushing. Now, this is arterial trace, and we can get a lot of information from the arterial trace. So first of all, if you look at this, if you start from here, this is the systolic upstroke, and it goes right till here. This is the peak ejection of the left ventricle and peak systolic pressure. After that, the ejection starts declining, and finally it stops here. So this is a dicrotic notch, and this here now is the diastolic runoff of the diastolic period, and the bottommost part is the diastolic pressure. The difference between the systolic and the diastolic is called pulse pressure. And here, this entire area is under the systolic portion, and this is the area which is equivalent to stroke volume. This entire area is equal to the stroke volume. And here, this is the diastolic period. And if you take this entire area and draw a line midway through this, this gives the mean arterial pressure. However, this is not the only information that we can get from the arterial line. We can get much more information. So if you look at this systolic upstroke, right, the higher the systolic upstroke, greater the stroke volume, 1. And if it is going vertically upwards, the more vertical it is, greater the contractility of the left ventricle. Now, similarly, if you look at the diastole now, so this is the diastolic runoff. It is normally like this. If it becomes vertically downwards, that means systemic vascular resistance is decreased. because it becomes easier for the blood to flow across, and it runs across rapidly. So the diastolic runoff is easier and faster. So it goes down vertically in cases of decreased systemic vascular resistance. If the systemic vascular resistance is increased, then it will become even more shallow. Then you come to the dicrotic notch. So in cases of increased systemic vascular resistance, the dicrotic notch moves upwards. And in cases of decreased systemic vascular resistance, dicrotic notch moves downwards. And this happens because of something known as reflection waves, which I shall explain. Now, the other thing is that all these factors can be looked into and should be looked into to get the maximum information from the arterial trace. So one more thing is, why does the dicrotic notch occur? So the dicrotic notch earlier was thought to be due to aortic valve closure and waves reflected because of that. However, it does coincide with the aortic valve closure, but it is not because of aortic valve closure. It occurs because, there are the forward waves coming because of the blood flow from the left ventricle. And at the same time, there are something known as reflected waves which come back from branching points in the femoral artery or wherever your arterial line is. Reflected waves come back from branching points of the arteries and they collide. And when they collide, you get this notch. So that is why you get a dicrotic notch. Now, moving on to something known as windkessal effect, which is related to compliance of the aorta. You have the resistance which determines the blood pressure, but there's something known as compliance also, which determines the blood pressure. And this primarily is the compliance of the aorta, which is a very compliant structure because this wall has a lot of elastic tissue. So it stretches when blood flows into it. So if you look at the diagram here, blood is flowing in from the heart in systole, and here is moving forward, but at the same time, it also distends the wall of the aorta. Blood goes into the wall of the aorta also because it's elastic and distends it. So this is occurring in systole and blood is moving forward also. Now in diastole, blood has moved forward, but at the same time, the distended wall of the aorta collapses now in diastole and blood is pushed forward. And this is why there is a diastolic flow also during the collapse of the aorta, and that is why the diastolic flow occurs. So this is known as the windkessal effect, and it's related to the compliance of the aorta. Just like you have compliance in the lungs, you have compliance in the aorta and the arterial system. As we move distally towards the periphery, the compliance of the vessels decreases because the elastic nature of the blood vessel decreases. They become more vascular. Now I talked about reflection waves leading to dicrotic notch. So these reflection waves are because of the forward propagating incident wave hitting the branching points in the vessels. And then there is a reflection back of these waves, and they give rise to resistance or what can be called impedance. So there's another term which is impedance in hemodynamics. There is resistance, there's impedance, and there is compliance, which I talked about. So this occurs, as you can see here, this is the forward coming wave and hitting the branching point. And from the branching point, you get these reflection waves back and they collide. So obviously the resistance increases. And this gives rise to the dicrotic notch apart from increasing the total resistance, which is called impedance due to reflection of the waves. So to summarize all this, the systolic trace is due to propagation of the forward incident wave and backward reflection of waves from various branching points. The diastolic flow is from the reconstituted blood stored in the aorta. Aortic pressure is different from peripheral pressure. As we move away from aorta to periphery, the SPP rises and the diastolic blood pressure falls and MAP remains same. Femoral and radial systolic blood pressure is greater than brachial by around 20 mm Hg. The dicrotic notch moves distally as we go down. The systolic part narrows and becomes taller, and there can be some variations in this due to vessel properties. So you may not get the same kind of trace in the femoral or radial artery all the time. There can be some variation, but very important to note is that as we move distally, the systolic pressure becomes higher, the diastolic becomes lower, but the map remains the same. That is very important. So now just look at it from a clinical point of view. This is taken from Hall's textbook of critical care. And you see here now, this is a normal trace in blue. And this trace here is in a patient with cardiogenic or hypovolemic shock. And this is in a septic shock patient. So if you look at septic shock, what happens in septic shock? In septic shock, if you have a good volume circulating, the ejection fraction is good, the contractility of the heart is good, and stroke volume is good. So you can see it is going vertically up as compared to this. That means the contractility is better. And you can see the height is also more. So the stroke volume is also good, which is what happens in a volume resuscitated septic shock patient. And because SVR is low, the dicrotic notch has moved down and the diastolic runoff is more vertically downwards, right? Because the systemic vascular resistance is decreased. Now, if you come here in cardiogenic shock, what happens? The ejection fraction or contractility is decreased, the stroke volume is decreased. So the amplitude of the upstroke is decreased, as well as the amplitude is slanting more. That is, the contractility is less. And the dicrotic notch has moved upwards because the systemic vascular resistance is high. And the diastolic runoff is also slanting more, again because the systemic vascular resistance is high. Same things happen in hypovolemic shock more or less because SVR is high, stroke volume is low. The only thing is contractility is good in hypovolemic shock most of the times. So this line upstroke would be more vertical upwards, right? So that is the way you interpret the arterial traces. And in real time, you can actually do this. This is not just theoretical. You don't have to do echo all the time or need advanced cardiac output monitoring systems. You can take a trace when the patient is bad and then you do some resuscitation, take out the trace again and compare it. And some monitors even allow you to freeze the images. So you can actually compare and get a good idea of what is going on as far as the hemodynamics are concerned just by looking at and analyzing the arterial trace. So once again, I will go through these constructed arterial traces. This is a normal trace. And now if there's a sympathetic surge in a normal heart, sympathetic surge can be because of so many reasons, you will get this kind of a trace. So here, what has happened is the amplitude is increased, the stroke volume is increased, and it is going upwards in the same fashion, and the rest of the things are same. Most importantly, the stroke volume is increased. So in a septic shock patient, what will happen if adequately resuscitated? It will go vertically upwards because the contractility is increased as afterload is decreased, and the volume would be greater, stroke volume would be greater, and dicrotic notch will move downwards and will slant less because the systemic vascular resistance is less. So in a hypovolemic shock, here you can see the amplitude of upstroke is decreased because the stroke volume is decreased. Also, it is going more vertically upwards because contractility is increased, and because SVR is high, the dicrotic notch goes upwards and it is slanting more. In a patient with severe cardiogenic shock, the amplitude is less, the contractility is less, so you'll get this kind of upstroke. It will be slanting more, and the amplitude is less of the upstroke, and the diastolic runoff will be much more shallower because there's increased systemic vascular resistance. So this is, the classic traces, and this is what you expect. And if you understand this, you can make out a lot more from the arterial trace. So if you look at this real trace, this is picked up from my ICU. The blood pressure is 143/85. So what do you make of the blood pressure first of all? So this is hypertension. Any blood pressure more than 130/80 is hypertensive. and the pulse pressure is wide. Any pulse pressure more than 60 is wide pulse pressure. So why is the pulse pressure wide here? Why is the pulse pressure wide? So the pulse pressure is likely to be wide because of atherosclerosis. The commonest cause of wide pulse pressure is atherosclerosis or hypertension, which leads to a rigid artery. So the aorta becomes rigid and there's an increased pulse pressure. Now, if you look at the arterial trace, this is going vertically upwards and the amplitude is good. So that means that the heart is in a good shape, the contractility is good, stroke volume is good. And if you look at the dichrotic notch here, the dichrotic notch is normal and the runoff, diastolic runoff is good. So systemic vascular resistance is good. Now, if you look at the peak systolic pressure, there is a slight variation with respiration. So that is a normal respiratory variation. It occurs in all patients. The respiratory variation is present to some extent with all patients. However, if you were to analyze this for fluid responsiveness, I would not say that this patient is going to respond to fluids, just as a matter of point. Now, what is this slide showing? Any guesses? So if any one of you has gone into the history of blood pressure, this is an iconic picture from Stephen Hales calculating or measuring the blood pressure for the first time ever in the year 1774. He cannulated the artery of a horse and connected it to a glass rod. So you can see the glass rod and you can see the red column of blood in the glass column. So this was the first time it was ever demonstrated that there is a blood pressure in an animal. The human beings came much later, and it is now 250 years since this was done. We still do not have a nice way or an easy way to continuously calculate the cardiac output. Something which can give us continuous cardiac output monitoring. It is still not very easy to get continuous cardiac output. So that is the slow progress of medicine that we have. Now, coming to the factors which determine the various components of blood pressure. First, we have systolic blood pressure, which depends on stroke volume, SVR, and to some extent on aortic compliance. Second, we have diastolic blood pressure, which depends mainly on SVR. Third, we have pulse pressure, which depends on stroke volume and aortic compliance. And fourth, we have MAP, which depends on SVR and cardiac output. So these things also should be very clear. Now, next we come to something known as pulse wave amplification. So this is what is called pulse wave amplification. You can see here, this is the aortic root trace, subclavian, axillary, brachial, radial, femoral. We are moving away from aortic root. And what do you see? You see that the systolic portion is becoming higher. That is, systolic pressure is becoming higher and the systolic portion is becoming narrower. And the diastolic pressure is becoming a little less, and the dichrotic notch is occurring later and later. This is the dichrotic notch in femoral, and in radial is here. So as we move away from the center to the periphery, the systolic pressure increases, the diastolic pressure decreases a little, and the map remains the same. That is very important to realize. However, in sepsis, there is gross vasodilatation. So there can be some difference from this in sepsis. The other thing is here, if you note, this is the pulsations in arterial and capillary, which are practically absent. So by the time flow reaches the arterioles and capillaries, the flow becomes non-pulsatile. Pulse wave amplification occurs primarily because of the reflection waves which are present, and the arteries and the vessels become less compliant and more resistant as we move distally. Now, like I told you in the last slides, there is a slight respiratory variation in normal individuals as far as the pulse pressure and systolic pressure is concerned. Here we are seeing marked respiratory variation in a patient with ventilation, and such a marked variation is indicative of fluid responsiveness. This is showing in a patient on a ventilator. As you can see here, this is the peak inspiration and here expiration is occurring, and you can see marked variation. So this occurs because of heart-lung interactions. So what happens in ventilation is that during inspiration, the intrathoracic pressure rises. And when the intrathoracic pressure rises, it impedes the return of blood from the circulation into the right atrium. At the same time, it squeezes the pulmonary vessels, increasing the pulmonary vascular resistance, thereby decreasing the right ventricular output. And at the same time, because the inflow from the peripheral vessels into the right atria is decreased, the right ventricular volume decreases, so the intraventricular septum bulges more towards the right ventricle rather than left ventricle, increasing the left ventricular output. So all these factors, because of heart-lung interactions, lead to respiratory variation. Similar changes are seen in a patient who is not on the ventilator also, but they are very subtle. However, if the patient is grossly hypovolemic, then even in a spontaneously breathing patient, they can become much more marked. Now, this is a patient of cardiac tamponade, and here you can see this is inspiration, and here this is expiration. This is a spontaneously breathing patient, and you can see the marked variation in the arterial trace. So this is again very important. Always remember, cardiac tamponade is a differential wherever there is marked variation in your arterial trace, inspiration and expiratory pressures. And such changes can also occur in tension pneumothorax and asthma exacerbations. Now this is again cardiac tamponade. Here you can see this is a patient who is in tamponade and the femoral artery pressure is very low. And in red is the right atrial pressure, and in blue is the pericardial pressure, which are increased. So we drain this here, and when we drain this, you can see the appearance of the Y wave in the right atrial pressure, which had disappeared earlier, and the pressures have gone down in the right atrial and the pericardium. But most importantly, here you can see the femoral artery pressure has increased. Earlier it was just around 85, and now it has become 110. And you look at the trace now. So the trace here, you see the upstroke is slanting and very less, while the upstroke has increased and become more vertical, indicating stroke volume has increased and contractility has increased. And if you look at the diastolic runoff, it is much more shallow than it is here. And it is shallow here because when the patient is tamponade, there is sympathetic vasoconstriction. And when there is sympathetic vasoconstriction, it becomes shallow. And here, once the pressures are returned, the tamponade is released, the systemic vascular resistance normalizes, it decreases. So the diastolic runoff becomes much more vertical. So this is what I told you, and this is a real trace from Braunwald's textbook of cardiology, real tracing. This is being depicted here. Now coming to damping. So what is damping? So damping is a process or a phenomena which occurs in lines which go bad because of loose connections, air bubbles, or sometimes they can be underdamped also. And underdamped occurs again because of problems with the lines. So this is a normal tracing, this is a overdamped, this is underdamped. So to check for damping, one has to do the flush test. So it becomes important to check for damping mainly because one suspects overdamping. In overdamping, the blood pressure will become low. So when the blood pressure becomes low, you're not sure whether it is because of overdamping or whether it's actual blood pressure. So you have to flush the line fast by pulling on the pigtail. And when you pull it, there's a fast flush. And if the line is normal, you will get a trace like this. This is the flush here. And here you will see one or two spikes only. If it is overdamped, you'll get a trace like this. There will be no spikes like this. And if it is underdamped, it will be multiple spikes. When there is underdamping, the blood pressure is falsely high. Very important to know is, even if it is underdamped or overdamped, your map remains the same. Now you look at pulse contour analysis also when you analyze the arterial traces. So pulse contour analysis is used for giving the cardiac output, and this is used for both non-calibrated, which is your flow track Viglio, or your continuous cardiac output devices like Pico and Lidco. So here, this is pulse contour analysis used for continuous cardiac output monitors. And here you can see this is the equation. So first you inject saline and you calculate the cardiac output, from which you get the patient specific calibration factor determined with thermodilution, that is multiplied into heart rate, and that is multiplied into this entire area. And this here is the area of the pressure curve, which is this. And this is divided by systemic vascular resistance and compliance of the patient, which are determined by the cardiac output monitoring device when you do the thermodilution by injecting saline. And this is multiplied by dP by dt, which is shape of the pressure curve. So this together gives the cardiac output, which is determined by your cardiac output device. And this is the continuous cardiac output. That is your Pico or your Lidco. Then you have your uncalibrated cardiac output flow track Viglio, which is stroke volume into K into pulsatility. So K is a constant which is given by the system itself, and it is derived from the data of thousands of patients, and the factors which are considered are age, body weight, body surface area in determining K, while pulsatility comes from the shape of the pressure curve and the area under the pressure curve. In real time, the flow track Viglio system keeps calculating the pulsatility, and here you get the stroke volume, which gives you the cardiac output if you multiply by the heart rate. So I thank you for your patient listening, and if you have any questions, please put them up in the chat box.